Hello, everyone. It's Dr. Jensen from Dean's Chat. If you're on the fence as to whether you want to join the American Podiatric Medical Association, jump on in. It's a new APMA. Whether it's advocacy concerns, scope of practice, billing and coding, consider membership at the APMA as your professional insurance.
Hello, everyone, and welcome to Dean's Chat podcast. My name is Dr. Johanna Richey. I'm an assistant professor at Midwestern University in the Arizona College of Podiatric Medicine and the co-host for the Dean's Chat podcast. Today, we have a special episode as I am not joined by my traditional co-host, Dr. Jeffrey Jensen, but instead, we have a really excellent episode where we have Dr. Byron Hutchinson, who I'm really excited to have on the show as a legacy career professional in the podiatric space. And who better to come and be my co-host than one of his prior residents? And we talk about mentorship and teaching, and Dr. Hutchinson's career is outstanding for this. So I'm really excited about today's episode. So I'd like to introduce first Dr. Byron Hutchinson. Thank you so much for coming on the podcast.
Absolutely, my pleasure.
And Dr. Lindsey Hjelm. Dr. Hjelm, thank you so much for kind of stepping in to kind of help me feel like I have a little more security in interviewing Dr. Hutchinson today.
It's great to be part of this duo.
It's, we're pretty informal here on Dean's Chat. I think some of you might be familiar with some of the episodes, but if it's okay, we'll go by first names, Lindsey, Byron, and Joe. And what I'd love to start with is, Lindsey, we're going to get you on for your own kind of special episode where we can chat. But just to give a little bit brief intro, Lindsey and I met through some of the AO courses that we've been working on together, and kind of hit it off. Some people you just resonate with. And as I've heard you talk about Dr. Hutchinson, it reminded me so much of my experiences with Dr. Jack Schuberth. And so again, when we had the opportunity, we had reached out to Dr. Hutchinson to see if he would be interested in coming on. And I just thought, oh, this is so perfect to have that opportunity for you to come and be a part of this. So thank you. It's like my breath moment. All right. But we're going to focus today on Dr. Hutchinson's career. So Dr. Byron Hutchinson graduated from the California College of Podiatric Medicine. I'm curious, what kind of got you interested in podiatry to begin with? You had done some undergraduate work at Washington State University in microbiology, and then also ultimately earned your bachelor's degree in medical science. So how did you find out about podiatry, Byron, and what was it that got you interested?
Yeah, actually, when I was playing football in high school, I had a turf toe injury. And one of my dad's friends, Dr. Armstrong, was a podiatric physician in the area, and I saw him, and I kind of got interested in that because I actually had a good outcome with my turf toe, and I was able to continue to play throughout the season. And so I kind of got interested that way, and I spent some time with him and kind of being mentored in my senior year in high school. And from there, it just kind of went from one thing to another. I went to Washington State, and I kept in touch with Dr. Armstrong. And as time came around to decide what I was going to do, he was a big influence in that.
It's so neat to hear different stories, and sport athletes and athletic injuries especially are a common theme that we see in terms of how people find out about podiatry. You decided to go to the California College of Podiatric Medicine, which was a incredible inspiration for teaching hub, big biomechanics. What was your inspiration to go there? Was it regional, coastal, or what was the draw for you?
Part of it was regionally, but it was also back in that time, that school at the Western Addition in San Francisco was a pretty good school, and as you had mentioned, big in biomechanics. And not that I felt that I was going to be a biomechanic guru, but I felt that it probably fit me the best, and I just decided I had a choice to go there. I also had an opportunity to go to Creighton medical school, but I had some help in getting to that school, and I didn't necessarily want to do that without doing it on my own. So the choice came up, and I decided to go to CCPM, and that's where I started.
Oh, that's outstanding. And then you went on and did the Waldo residency program, which is now the Swedish program. Can you talk a little bit about what that experience was like And I'm also very curious where your timing with Dr. Christensen and Dr. Schuberth may have been in that, because I think
Sure.
you guys were close, and I don't know if
Yeah.
there was co-residents or chief residents involved in that.
Truly a
Yeah.
brotherhood over there.
Yes.
Yeah.
Yeah, there's a pretty good story there, and I think that when I look back on that, when I got out, only about 70% of the class got residencies, and out of
Wow.
those, there was probably only about 20% or less that were 2-year programs. So I felt very fortunate to get the Waldo program. Obviously, like everybody, had some other opportunities in Oklahoma, but I took that program, and Dr. Schuberth was my senior resident. And of course, he always lets you know that that's the case. I'm always going to be his junior resident. And, I wear that as a badge of courage now because, we've both kind of gone our different ways in terms of what we've done to influence the profession. But I'm very proud to be associated with him and also with Dr. Christensen, who was under me. So
Okay.
when you really kind of look at it from my perspective, I had Schuberth on one end and Christensen on the other. And it was a very exciting time because we were completely competitive and trying to really just take the ball to the next level. And I felt very comfortable that I had those two around. So it was a very good experience that way. And I think that coming out of that program and recognizing that I was fortunate to get one of those 2-year programs in the country, we all three of us kind of just felt like we were not going to settle for just going out into practice and not really being heard. And that's kind of what happened. We were all kind of in it together, and we did a lot of ACFAS stuff together, ABFAS, and did a lot of lecturing together and really collaborated over the years. And we've had a very long friendship regarding that. So it's been really kind of an incredible journey with those two guys, and then certainly with the opportunity for a 2-year program back then. And when I was at Waldo, we really did everything. So it's so different now when you look at training. Back in the day, at the end of everyone was admitted, whether you had a bunion or a hammer toe or an ankle fusion. So by the end of the week, we'd have probably anywhere from 10 to 15, maybe 20 cards of patients that were on the floor. And we managed everything. So, it's become much more specialized now, which I think is the way it goes. But back then, boy, it was a real challenge that way to integrate into the hospital system that way.
Hutch, I was going to
Yeah.
kind of segue with that too. And if it's okay, Joe, like, what do you think put Seattle on the map? Like, do you think that brotherhood and that competitive environment kind of made the West Coast then also like a catalyst for other programs to develop? Like you said, Schuberth then was down in San Francisco, or like you guys all went in a lot of ways along the West Coast. And I feel like there's a birthplace of Seattle. And I'm curious where you think that microculture or that culture, like, was it the brotherhood that kind of initiated that?
That's a great question, Lindsey. And I think that, and I'll answer that with kind of two parts, and you were part of one of those parts. I think what the environment for just learning and excelling was there. And, that was generated by Gary Dockery, who was our director. And it was a well sought after program. And the camaraderie, I think, wasn't just Jack, Jeff, and myself. It was all the attendings. And it was almost like a family, to be frank with you. And when I got out of that program, and I did the Swedish program for a while, and then, as you know, Linz, I was doing the Franciscan program. I wanted to create that same model with the Franciscan Foot and Ankle Institute, and I really felt like my time there, which included you and the residency and the fellowship, it was a microcosm of what we started with when we did our program together. And I'm actually very proud of that, it it gets lost in the noise sometimes that those things are important. And, people, I think people learn differently. And certainly there's some programs that are really rigid. And those programs, certain people have to be in those programs because they're rigid. I came from a program that wasn't like that. So if you compare and contrast Waldo with another great program at the time was the Podiatry Institute. Well, it's a great program, and I think equally as good as our program, but it was a little more regimented than ours was. We had a little bit of freedom of thinking and those kinds of things, and that's kind of what I felt that I wanted with the Franciscan Foot and Ankle Institute, to have that freedom to do that. So I feel fortunate that I started my career that way and really ended my career in a situation that was very similar to that.
Joe, how would you describe, like, because you're on a different face of, academic approaching students and things, I felt like we did have a lot of autonomy when I trained. And I think maybe Hutch would say that attracted certain candidates to the program, people that probably were self-driven and motivated to explore their interests within the profession. And it gave us the freedom to, but still knowing we were going to work hard and get everything we needed. How do you feel like that compares as you're molding students, through medical training and schooling at this time frame?
Yeah, I love that. And I think you hit it exactly right. We tell students all the time, externships are like dating. You have to go out and try on a bunch of different programs, and they're interviewing you for sure. But you're also trying to figure out, is this the right fit for me? Is this where I'm going to learn specifically a skill set, which is surgery? Is this the best place for me to learn something like surgery, not just sit in a classroom and learn facts? Because those are two different skill acquisitions. And it's interesting because that's definitely not something that I think I appreciated as a student, but very much now on the other side, recognize there are very different teaching styles, but more importantly, different learning styles that when you're learning something like a hands-on skill that you may learn very specifically. And so to Byron's point, do you prefer Hutch, by the way? I'm happy to call you Hutch.
Hutch is fine. Yeah.
Okay.
I can't even call him Byron, to be honest with you, because I feel like I'm Hutch's wife if I call him that. But
totally, I get it, because that's
my love. Like, shout out to Aaron, but I'm like, I can't call you Byron.
It's funny, right? Like our mentors, it's still hard for me to call Dr. Schubert Jack. Like I'll call him Shuby, right? It's Schubert, Shuby. Ford is the same way. I can't call him Lawrence. Like that's just too weird. So he will always be Ford. So we'll stick with Hutch. But you had said, Hutch, that you wanted to create this environment for your residents to have some of that autonomy to learn. And I think that's really important because that is what some learners need, not just what they want, but it's actually what they need in order to develop that skill set. And then there are other programs that maybe are much more regimented, much more, I don't want to say structured, because every program is structured. It's just what that structure looks like can be different. But some students and residents, they need someone there. Like, you will be here, and on this day you're doing this. And then when you're a second year, you get to do these kinds of things. And that's really what they need to learn those kinds of skills. And it's not that one is right or wrong. It's really what the learner needs. And this is so much too, Lindsey, as we've gone through all this AO, and Hutch, I know you were involved with AO stuff too. Like, this is the whole, thing that AO is built on, is we develop curriculum for what our learners need, not what they want. And if we cater to what they want, we will be missing what they need. So I would love to get some of the experiences, Hutch, when you started having taken what you learned when you were a resident. And then I should comment, you had been the medical director for the Franciscan Advanced Foot and Ankle Fellowship. But even previous to that, you were the residency program director for close to 30 years at the Franciscan Foot and Ankle Institute. So you've been teaching residents for, well over 3 decades. What was it like to start that process from the ground up? And how did you figure out how to provide learning opportunities in a self-directed and for more of the learners that needed some of that space to think freely, to let their curiosities spark interest, and then go into fostering that kind of learning?
Yeah, I think I try to emulate really what I had and what my experience was in my residency program, just because it was such a great experience. And I've always felt that the best way to teach is to lead and, make sure that when you're in the setting of surgery or in an academic setting, that the people that are around kind of understand what it is you're asking. I think sometimes educators get mired into the book or just what A, B, and C might be, and then miss what each person needs. And it took time for me to develop that. Early on, and I'll be frank, and Lindsey can tell you this. I think earlier in my career, I was a lot more patient, so I could take different students or residents, and I was more attentive to certain things. As my career developed, and it's like anything, you do it long enough, and then you're getting more complex things in your practice. My patient level changed. So I had a little bit more difficulty, and I'm just being really honest. I had a little more difficulty dealing with first-year residents. And really, it's because when you're doing a Charcot reconstruction, it's very hard to have a first year and spend the time when you want to get out of there in 2 hours versus what I was later on and having fellows and third-year residents and allowing them to go. And the other thing I think that took a while for me in terms of my style was to let people not get in trouble, but have confidence in the room. So I let the residents and my fellows do a lot of the work and I let them struggle. And I will tell you, I learned that from Dockery. I mean, I remember a time when Dockery said to me, "Listen, there's nothing you can't do that I can't fix." And so there's a certain, and I think that's a different teaching style too, because I think some people, it's all A, B, and C, and you got to lead them along with, hand in hand. Then there's other people, I think, to get confidence. The only way you're going to get confidence is to have the real confident person in the room allow you to get confidence. Yeah. And that's a hard thing for an educator to do because, again, these patients, they're really putting their trust in you. And I used to tell my fellows and residents all the time, listen, the patient I signed a consent form to violate this patient. You got to understand what the responsibility is. And sometimes that message gets lost because as we're training, we have this concept that we just should get the blade all the time. And you have to remember that if I allow a resident or a fellow to participate in that patient it's a trust.
Yeah.
So I think at the end of the day, I always wanted to make sure people understood that the training was important, but it was also important to understand that you had to respect that process and trust that process, and that the person that's involved in your training is going to get you there. That's the other thing I think a lot of times residents and fellows don't understand is while they're going through this, we usually know what's best for them, just like students, right?
Yeah.
There's a curriculum, they might go, well, what do I need to learn this for? And then on the other end, you start to go, wow, I'm really glad they spent the time to do that. So it's kind of dynamic that way. And that was always kind of my style, but it took several years to get to that point.
Yeah. And I love that you brought up this idea of trust because, again, it's so easy in the current medical system to forget the most important part of what we do, which is taking care of patients. The right. system now is bogged down with so many other things, and that's not the focus of what we need to talk about today. But in that chaos, right, of sitting in the rush hour traffic of the medical system, it's easy to forget. And our residents, I think it's easy to feel like you're entitled to be able to do something when there is no entitlement that's here. It is a privilege to take care of patients, and developing trust with your attendings goes both ways. And I'm curious, and Lindsey, I'm going to throw the ball back to you for this one. What were some of the things maybe that you remember in learning that kind of comfort curve with each other? I love Dr. Loader's comfort curve reference. How did you develop those trusts with Dr. Hutchinson when you were a resident?
I'm sure it's so different the way each of us would answer, but when you said that, you're dating different programs, I remember initially meeting Hutch, and I felt like you really don't carry any ego about you, Hutch, and that is so refreshing. I think there is something different about being on the West Coast, and I don't mean any dislike for anybody anywhere else. I currently practice in the Midwest where I'm from, but Hutch was such a conversational teacher. And I think for Hutch, the expectation to do well with him and to build your skills up leading up to really being more of a third year and working with him, you knew that expectation. You wanted to succeed. You wanted to impress, but there also wasn't this immense pressure because there was such great camaraderie there. And there was so much teaching ahead of the case. I remember we would always do pre-surgical rounds. And, first of all, that was a great way to help see what you did or didn't know, but then you had time to adjust your preparation ahead of the surgery. So I felt like there was great rapport. There was so much conversational components to teaching that I wasn't uptight when I was learning. I was excited to ask questions. I wasn't reprimanded or scolded. And I think genuinely there was excitement to teach and learn. And so that relationship that not just Hutch and I had, but all of his residents and fellows, it made the environment for learning really fun. And of course, there were days that were stressful. Of course, there were days that things didn't go quite as smoothly. And we can probably laugh about those things now, but I would just say the learning environment for me was really ideal. And I think it really welcomed kind of a richness to that. And I still think learning is fun, and I want learning to be fun, whether you're a nurse working in my clinic. I still have students that come in and visit me. And if it doesn't have a positive energy to it, then I don't feel like it can carry the same learning capability. While people do learn well under pressure and maybe some negative emotions or negative experiences, I would prefer to have the other. And there was a preparedness that we had, but an excitement too and a joy. And so I would say that really shaped how then we had trust and worked together.
Yeah. What are your thoughts, Hutch?
Yeah, I think Lindsey said it perfectly. And of course, the part about just kind of being one of the folks was one way I felt that it made people comfortable. I mean, I think ego can be a real problem in the medical profession. We've all experienced it, and it really doesn't serve anybody. And this went both ways. If we were in our pre-rounds, and I was way off base on something, they felt comfortable to say whatever they wanted to say. And, it became kind of a game. And some of these really complex cases, which was fun for me, was just seeing them kind of struggle with, okay, so what are we going to do with this talus, that's on the floor and dislocated? Am I going to put it back or am I going to take it out? And, when you've done it 100 times, it's an easy question. But when you're faced the first time with that, so I felt it was important to let residents and fellows kind of figure out what they felt they were going to do and then share that. Of course, then I jump in at the end and go, that's just not going to happen. We're going to do it this way. But it's especially for a lot of the really difficult stuff. I mean, and let's be honest, as you get into your career and you're into fellowship, talking about a hammer toe and a bunion isn't necessary. I'm not downplaying it. It's all very important. Yeah. But it's the real complex stuff that I think people struggle with. And what do we do with complications, or what do we do for, this was always a big thing for me. You've got plan A, where's plan B, plan C, and plan D, because that's going to happen in the cases I used to do. So I think that what Lindsey was talking about, I think that's kind of where I wanted residents and fellows to go so they could get that confidence.
I think there was a
I love
component too, sorry, just to say without ego, and I think that's great, Hutch, is then we were never allowed to have an ego, not with students, not with visitors. I hope people feel in my practice I don't walk in with an ego, but there's also transparency to ask for help or to ask questions to say, like, I still call up our, residents and fellows and our friends and different people. And there's no shame in that because we never held ourselves on a pedestal in a way that was like, oh, we can't ask others. It's always a conversation. Education and learning and difficult cases are always a conversation. And I love that.
I love that. And actually, to kind of transition in that same line of thinking, Hutch, you have seen and been part of the advancement of our profession over the last 30 years because of the kinds of cases that you did do with the kind of expertise that you had. And I'm curious, as you've watched the profession evolve over the last 20, 30 years, what do you think has been really the most exciting changes that we do now in foot and ankle surgery?
Yeah, that's a very great question. And just to put it in perspective, when I got out of my residency program, the biggest thing that I did was an ankle fusion. And at the time, we had a throwaway Johnson & Johnson arthroscopic deal. So it was plastic and you could just put your eye in the instruments. So we'd stick this thing in an ankle joint and go, what the hell are we doing here? Because we couldn't do anything. So if you compare and contrast that to what I look in my career, if you were to say to me back in 1984 that I would be doing muscle flaps and Charcot reconstructions and total ankle replacements, I would have told you that you were out of your mind. But that is how far the profession has gone. And I'm extremely proud of the fact that it has moved in that direction. Not only am I proud that it's moved in that direction, but I can safely say, if you look at the best people in orthopedic foot and ankle, and you take the best people in our profession, it's exactly the same. And you could not say that 40 years ago. Yeah. So it's incredible where the profession has come. And I always say this too, and I remember telling Lindsey this. When I got out, we were worried about getting hospital privileges. Okay. I mean, seriously, I was a dog on a bone trying to be in a medical group to say, hey, listen, I can do this and I can do that. What's changed now is we're part of the medical profession. I mean, everybody knows who we are. The difference now is just how do you get paid, right?
Yeah.
That's really a big part of this. So it's tremendous where the field has gone.
And I love that, because then you already kind of answered, well, maybe not. I won't make any presumptions about how you might answer, but in all of the advances, where do you think the biggest challenges are in the next coming years?
Yeah, I think two of the biggest challenges, one is going to be, again, how do you get paid?
Yeah.
Okay. And the second is holding your own as a physician and not letting corporate America tell you what to do. And, it's hard because they're big entities. And, if you're trained, for instance, you're trained on some system, you get into a hospital system and they tell you, you can't use this because it's too expensive. Well, we're going to have some sort of pushback because it's the patients that suffer from that. And I think those are going to be really probably two of the biggest challenges. The third challenge, I think, is going to be, and this may not be a popular thing to say, we have a lot of podiatric medical schools.
Yeah.
And
you're talking to the right person there, but I have strong opinions in this regard.
Yeah. So the question is, supply and demand, right? And what's best for the community that we treat is having the best doctors come out of the best schools, just like our allopathic or osteopathic colleagues. Now, not to say that they're not struggling too, because they are, because the cost of medicine's high. We all know this with the bills that we had to pay. But I think that's going to be a big challenge, is to get the quality people into the programs and have the right number of schools with that population of patients to get residency programs. I think that's going to be a big challenge. And then the last thing I'll say is, we're kind of stuck with the model we have. I'm not saying it's a bad model. It's worked, and I think the public knows what we are. But to be frank with you, now that I'm on this side of this, it would have been nice if we had more of a dental model. And what I mean by that is, you would get out and be board certified in general podiatry, or you might be somebody that wants to do just sports medicine, or you want to do surgery, or you want to do something else. I mean, I think, unfortunately, we didn't go that route. But I think where we're at is okay. It makes it difficult, because I don't think everybody gets out of school and residency and feel like they want to be surgeons. And that can be a problem too, if you spend all this time and money and you say, well, you know what, maybe I would have been better if I was just doing wound care. Now, it doesn't mean you can't do that, but we didn't have pathways for people to get into that. So I think that's something to think about. I don't know that we're going to change it or we need to, but it is something that I look at on this end and go, yeah, that's kind of tough.
Yeah, I could definitely mirror a lot of those sentiments. And, there are no answers to some of these things. Right. And I know, talking with Dr. Chang, actually Tom Chang, about, I don't remember exactly when, and you had been the past president of the American Board of Foot and Ankle Surgeons in, I think, the late 90s, if I remember correctly. And it's possible maybe some of these changes were happening during your tenure there, when the decision was made to make all of the residency programs surgical. And the idea was to really elevate the bar of the profession. And there was so much good that did come from that. But you're right, it is now a surgical profession. And so people that come into it and they genuinely aren't interested, or maybe, and again, the reality, some people, it's just not in the cards for them, right? It's not the skill set they have. They recognize that very quickly, right. But their residency training is still standardized to be the same kind of 3-year surgical training program. Right. And there are definitely, again, there's so many different conversations we could have in this space. But rather than me taking all the time, I'm going to throw the ball to Lindsey to see if she has any strong feelings or thoughts in this regard before we transition a little bit. But I can definitely appreciate some of those as big, future looking challenges.
Mm-hmm. No, I would just say, I mean, Joe knows I reached out recently to some efforts that I think we all care about, would just be that great applicants continue to apply to the medical schools. And, this platform is a great way to advertise in any way for those interested, that there are efforts to try to connect more people with understanding what the profession does have to offer. And I think that our profession could be in danger if we don't find a better way to help mobilize young, qualified individuals to pre-podiatry, thoughts and applications, and looking at what it has to offer and setting them up with mentorship or individuals that have been successful and made a difference in their communities in a positive way. But I do also like the idea that people could specialize sooner. I think we probably all see a lot of second opinions, and I'm sure patients of ours have sought second opinions, but at times, if we are trying to be a master of all different things in foot and ankle, I think many of us are capable of doing so much, but there is something to benefit to say, hey, really, I do more rear foot than I do forefoot. Just different things like that to say, let's really get patients to the right surgeons. And there's also so much great foot and ankle care that may not be surgical. And
absolutely,
I would love to just encourage people to embrace what their skill set is. I think something that Hutch just has taught me too is that really this idea of there being a scarcity principle, like there isn't enough to go around for others. I feel like you've helped teach me to say there's more than enough for others. You've shown me, there's no sense to be jealous or thinking that there's not enough for me to achieve or to go out and find success in reality. Like, you can make that for yourself. You can carve it out. There's more than enough for others, and encourage others to be their best. That doesn't have to take away from anything you achieve. So I think that's a great message too, that I would share as part of Hutch's legacy, is like, go out and do it and represent your program and the people that taught you well, and make a difference for other people's teaching, learning, or just in your patient population too.
Ooh, that's a beautiful mic drop moment. So we're going to take a moment to hear from our sponsors, and then we're going to come right back.
Did you know APMA provides help with public health initiatives such as fall prevention, opioid abuse prevention, and addressing health disparities?
Did you know the APMA provides over $400,000 in scholarships annually to students pursuing podiatric medicine, helping the next generation of foot and ankle specialists?
If you're serious about this profession, if you want to grow, to lead, to make a lasting impact, join APMA today.
You know, I took some notes down when we were like, hey, you're gonna do this podcast. And I was like, gosh, I want to be thinking about the things like, Hutch, you've made a huge difference in a lot of people's lives. And that's something that really stuck, it sticks with you. There's people that teach that don't want their trainees or other people to reach higher heights than they have. And Hutch has said, like, go for it, like move the mile marker, I might not be moving the mile marker as much as some of your other people, but, teach their own. Like, what are you good at?
Right. Well, and that's a good point too. I think that you give people the opportunity, and everybody finds their own compass. Absolutely. Everybody can't do flaps. Everybody can't do Charcot. Some people don't even want to do Charcot. Mm-hmm. Maybe it's trauma. Maybe it's the ankle trauma that really gets your motor going. So I think that's the one thing that I've learned over time is people just have to find their own bubble, but they have to have the opportunity to get to that bubble.
Which goes back to your idea of kind of giving people that holding that space for them to ask those questions. And I love that. And this is why it's also so fun to have someone that had these experiences directly with you, Hutch, is to hear, because I can ask you, so just some reference for the audience too. Your residents came down and spent 4 months with us when I was a resident in San Francisco. Yeah. And so Craig Clifford was like my counterpart. And he was just such an amazing human being, wonderful guy, fabulous surgeon. And you're absolutely right, Lindsey. There was zero ego. He could have shown up and been a very different version of himself if he wanted to, but that just wasn't at all who he was. And we had such a great time. And there was some hard cases and hard experiences that we all went through and navigated. But it was nice to have that common collegial experience. And you could feel that, so like when I hear you say these things, I'm like, check, like my experience with residents from the Franciscan program. Yeah, this all registers and checks out. And it's fun when you travel and you go and you're speaking to different people. There's always a few names that constantly come up in conversation. And Hutch, you're one of them in terms of, again, people that are willing to go out there and do the work and talk about it, and not in a way of like, look at all this cool stuff that we're doing and how wonderful I am, but really in a way of let's push our profession, let's advance to what we are capable of doing within our scope of practice. And so where I'd love to kind of transition, I think, is possibly a little bit of a passion project of yours. You've been involved with the Yucatan Crippled Children's Project for longer maybe than even being involved with residency training. It was a little hard to tell exactly the start and end dates on some of that from your very robust CV, but I'd love to hear your take on how did you get involved with that program? And for people that aren't familiar, can you talk a little bit about it?
Yeah, so there's two parts to that question. One, I got involved really because Dr. Sutherland and Dr. Dockery were going down to this Yucatan project. And I always felt like I wanted to do some humanitarian work. But on top of that, I'm kind of an amateur Mayanist. So it was an opportunity for me to go see some Mayan sites. And And, I studied that in school, but I knew I couldn't make a living being a Mayanist. So that became the hobby for me. And doing the Yucatan Crippled Children's Project kind of married the two. So that's really how it got started. And that's interesting too, because it started out, it now, and Lindsey was down there, it's now in a Red Cross hospital, and we have some orthopedic colleagues that work with us, and it's all computerized and all that. I'll tell you a really quick story. The first time I went down there, it was a hospital with dirt floors.
Yeah.
And we were doing a 2-year-old kid that had a club foot. And back then, we didn't do any Ponseti casting or anything like that, because the only opportunity you had to fix this was surgery. So I was doing surgery on this kid, and the anesthesiologist was putting the kid to sleep. And I looked over, and he had a cloth, and he was pouring something in this cloth. And I just looked at him, and I'm like, are you dropping ether? I mean, I'd read about it, but that doesn't happen in the United States, right?
Yeah.
So this kid got under anesthesia with ether, and the kid did great. The anesthesiologist did great. But that's how that project started. And then just to see over the years, over the last 35 years that I've been doing that program, to the point now where not only is the care better, because we have a care team down there, the bulk of the procedures have become more sophisticated too.
Mm-hmm.
I mean, I don't do this in the United States, but I lengthen femurs down there. I do all kinds of stuff, because if you've got that skill set, a long bone's a long bone. So we've been able to kind of take that to another level. And I've always told this to my residents and fellows too. I go down there and it's hard work, but I get back and I feel very good that I did something really good for people, because these people appreciate what you do. And then I'd meet Lindsey Monday morning in the clinic, and Mrs. Jones was pissed off about this or that. And it just makes it stimulated me to get back into, why did I get into this in the first place? And that was to help people. And I will say, sometimes it's difficult in today's world when you're seeing 40 patients in a day, like you are, Lindsey. I never saw 40. But if you're seeing that many patients, it's really hard to have that sediment sometimes, because people in the States bitch about everything, right? So
you're, to your point, like resetting your empathy, not just you, Hutch, but for me, I think for all of us and future practitioners or current practitioners, what helps you hit a reset? Because I think burnout and practicing medicine in the volume production setting that we're in is really hard.
Yeah. Yep.
How do you reset?
I would encourage anybody to do it. If I could look back, of all the things that I've done, whether that's ABFAS or whatever, the two things that I'm proudest about are my involvement in Steps to Walk, which is Mark Meyerson's program, and this Yucatan Crippled Children's Project, and then training residents and fellows. I mean, it's something that I know that it made a difference. I don't know how much it made a difference that I was president of ABFAS. So I think when you look at it from that perspective, those are probably the things I'm most proud of.
I love that. And again, it just speaks a lot to your character too, Hutch, that the things that at this phase of your career that you look back and you reflect on are the things that really provided the most impact and personal joy, not just professional prestige, if you will. And again, it's just very on brand for you. So I felt like I would highlight that. I would love to know though, as Lindsey said, this idea of resetting empathy.
Mm-hmm.
How did you recharge your batteries outside of some of the mission work that you would do on more of a consistent kind of day to day, week to week? How did you recharge?
Yeah, part of that, and I hate this word, work-life balance. That's kind of what we all use now. I didn't know that back then, but what I think was important to reset was to understand your priorities. And my family was always a priority. So I took my kids with me to a lot of the stuff that I was doing. I didn't know, and they're older now, obviously, but I didn't know whether that was beneficial for them at all. But now that we can talk about it as adults, they remember every one of those trips, even though Dad wasn't necessarily there. I was lecturing, and Aaron was with the kids, and they were out in Washington, D.C. having a great time, and I met them up for dinner. So that priority of understanding that, and then Dr. LeBaron, who's passed away, said this to me years ago. He says, you know what? You need to reset by going somewhere and doing a vacation every 3 months. Don't be the person that says, well, I'll do that next year. And it was some of the best advice I ever got, because resetting has really gotten harder, I think, than when I first started practice, because there's so many things coming at all of us in the profession, not only from, your hospital, but everything. So I think it's important to do whatever you need to do that reset. I think Lindsey's absolutely correct on that. And it can be anything. It can be a hobby, it can be golf, it can be whatever it is, but you need to find the time to fill that in. And the other thing to learn about that is the patients will always be there. Right? I mean, when you're first in practice, you think, oh my God, I don't know, I can't take a vacation because, maybe I won't be able to pay my bills. Dude, they're always going to be there. If you do
There's
good
great
work,
job satisfaction. Yeah.
If you do good, yes, if you do good work and you're good to patients, you're always going to see patients. So just take the time.
Yeah, that's beautiful. Lindsey, what are your thoughts?
Oh, I think very similar things. I think for me, faith has continued to be a really grounding source in my life. And to each person that may look different, but one biblical passage stands out to me, and it's to whom much is given, much is expected. And some people could look at that as like a badge of duty or a weightiness to it. But for me, I think with gratitude, I think, wow, I'm so fortunate to be in the setting I'm in and to help people. And I try to use that as a healthy motivation to be in a position to help others. But also there's a sense of togetherness or camaraderie that even if you're commiserating with one of your former co-residents, which I'm still on multiple group chats for, how great to go on to somebody about something that just didn't go well, or maybe did go awesome, and to go on about it with someone else and feel like you're not alone. And I think that can help people just hit a reset in a lot of ways, maybe not always from an empathic perspective, but I always do encourage people being in touch with their passions. How great, to be alongside Hutch and see, he loves the Seahawks. He loves Mayan culture. I do know he and his wife go to Hawaii annually. I think that you want to train with people that have that capability. And it was great to be with Hutch in a season of his life when I could see so many things come together like that. It provided excellent perspective. And while I worship the ground Hutch walks on, it was still he was very human to me and showed me and told me about parts of his career that early on I knew I was going to struggle. So here I am. I'm human.
Yeah, and that realism, right? Having good behavior modeled for our residents is also a reason to take a vacation. Hutch, I love the every 3 months thing, because makes me feel more human, where I'm you can feel it building, and it's I just need to take a weekend and not do anything professional and just dive into all things that are not podiatry for a while. And then you always come back feeling better after the fact. And I think once a quarter is what I joke to my husband. So I'm going to feel great now. I'm nope, Hutch gave me the validation and the permission I need a little mini vacation every 3 months.
Time to do it.
That's right.
There you go.
That's right. So we're going to spread that amongst the profession now, make your quarterly travel arrangements.
There you go.
I do want to circle back to the Mayan thing. How did you get into Mayan culture? What was it that sparked your interest?
Yeah, it was stuff I took several classes in high school, and just I've always been kind of a history buff. And then I got out of my residency and I took my first trip down to Mexico, and I just got the bug.
Yeah.
And it kind of escalated because I went on a river rafting trip down the Usumacinta River in Guatemala. And there were some Mayanists there, a couple of epigraphers, and some real big names that were doing this rafting trip, if you can believe that. And it was a week on a rafting on boats. And we went to all these different sites. And then I got asked back from one of the Mayanists there, Jim Orr, to go to the Mesa Redonda de Palenque, which was something that was done every 3 years. And it's where all the epigraphers and scholars went. And I got asked as an amateur to go. And, I was like a kid in a candy store for that. And it's just been a lifelong passion that way. And my kids and my wife went down to Guatemala on a trip one time, and we met a guy named Carlos, who was a Itzamaya, and we hooked up with him. And probably for the last 20 years, he's been a real good friend of the family. And every time we go down, he's a Mayan guide. He's one of the top 2 or 3 Mayan guides in Guatemala.
Oh, that's incredible.
Yeah. So it's just been, every time I go down there, he arranges something where I'm not supposed to be, right? We go to a place like El Mirador, and Richard Hansen isn't there at the time, who runs the project, and he'll go find the groundskeeper, and I'll go see something that nobody's supposed to see. So it's just stuff like that. And it's just been a lot of fun. And my wife is into it too, which was kind of a miracle. So it makes it more fun that way.
Yeah.
Not just me. And then when we go down to the Yucatan project, I mean, half the time I can't shut up when I'm showing everybody what's going on. So it's kind of a cultural day too when we do that. So it's kind of fun.
Yeah. Oh, that's really cool. At the end of the show, sometimes we'll go into rapid fire stuff where we talk about all things that are like just fun, random questions. So maybe this is a good, because we didn't even get to, I kind of figured this was going to happen. We're coming close to the end of our time, and I want to be respectful to both of your schedules. But just a brief, you've had almost 1,000 lectures, both nationally and internationally. So with all of the travel that you have done, where's your favorite place in the world to go?
Italy.
Oh, which part?
Yeah. Well, I like Rome. I've been in Verona several times, and up in Tuscany too.
All right. All right, Lindsey,
that's a tough question, because
it is a tough question.
So many of these places that are great, but I really enjoyed my time in Italy every time I've been there.
Especially if you're a history guy, because I mean,
bingo.
How do you beat Rome?
Exactly.
All right, Lindsey, your turn for a rapid fire. It can be just fun, silly questions, or heavy ones. It's up to you.
No, I was gonna ask Hutch where he saw his greatest impact in the profession.
I think my greatest impact in the profession, I think, has been some of the complex work that in my later career, last 20 years of my career, that I did, and pushing that ball, orthoplastics, muscle flaps, some of the things that I wasn't necessarily doing early on. So I think that's where I've seen the profession move in that direction, and I'm really happy about that. It's not that it's for everybody, but it just pushes us way into an area that's necessary.
Yeah.
So
how about what is retirement looking like for you?
Oh yeah, phase 2. What's phase 2 look like?
I don't really know if you're retired, but I just use that.
I'm semi-retired. Yeah, no, yeah. It's a great question, and I get that a lot nowadays, obviously. Here, it's very interesting, and this is for you guys. I remember getting up for breakfast. My wife's been retired years before me, and I'd get up and spend 10 minutes having breakfast, and I'm out the door, right? So everything was rapid. Mm-hmm. The only thing that's changed is it's just slower. The day is still filled, but instead of 15 minutes, I can sit there with my wife for 45 minutes or an hour and just talk. And if I want to get on the Peloton at 11 o'clock, that's what I do. And maybe I shower at noon. That can be a day, or I can have a day where I'm on the computer all day because I'm doing something with podiatry or whatever. So that's the key. It's just really slowed down a little bit. I have a grandkid, so it's, there's much to do there that I probably wouldn't have been able to do had I not been retired. So there's some good stuff, but again, I'm not retired to the point where I'm not doing anything. I made a pivot. I guess that's the best way to put it.
Right.
I made a little bit of a pivot. So I'm still active in International Foot and Ankle Foundation and doing stuff like that. So I keep things filled up, but it's been good. When you guys are ready, it'll be fine.
Well, we'll definitely have to have you back to talk more about, again, some of the lecturing that you've done and your work definitely with the International Foot and Ankle Foundation. Because I'd love to talk to you about, again, that in and of itself is an entire episode just in terms of the legacy that particular foundation has had on CME for our profession specifically. But I guess maybe the way I think would be fun to end is advice, and maybe advice that you would have given your younger self.
Probably the advice I would have given myself early on is, this is going to sound strange. Learn to say no when you need to say no.
Yeah, that's a hard one.
It is, because that balance we're talking about can certainly, what's very interesting about our profession is, and I don't mean this in a bad way, it's actually very good. It can use you up.
Yeah.
If you let it. So you need to take care of yourself. And sometimes saying no doesn't mean something's not going to come along. And I think we're all afraid of that, right? If AO says, you say you can't make it, well, they'll never ask you back. And that's simply not true. That's not true.
That's excellent advice.
Mm-hmm.
It's hard to take. Yeah. So that's good. These are things to constantly work on. But I love talking with some of our legacy faculty. There's so much perspective. And again, sometimes the things that you think people might feel or say versus kind of where you can feel your heart sitting. And I think that's actually really great advice. And yeah. So I'm actually, there are two things that I have tentatively on my back of my head where I'm like, it's just not something right now I can do. And you just gave me the confidence to be like, I'm going to have to say no, not right now. How about you, Lindsey?
Would you say in terms of advice or what I need to say no to?
Either one, but we'll go with advice. What advice would you give your younger self?
I would say that people never forget how you made them feel. And I don't say that to add weight on people's shoulders that might already be there. But I think there's an element of having just a really genuine interaction with a patient if you can, to hear them out and actively listen, even if you really do only have a few minutes with them. And I think that patient outcomes are better. I think that there's just something really wholesome about caring for a person that way, to say they probably won't remember everything I said about their first MPJ fusion, but they'll remember that I acknowledged, how painful it was, that their grandkids thing was coming up the next, month, and that we're going to delay that surgery, for something else. And I think that's even true just how people interact with me. And that doesn't mean that it has to be in a medical reference, but just how we treat and acknowledge others day to day, right? Like life is hard for everybody. So yeah, that would be my advice.
Yeah. And that's taking some of Hutch's advice, learning how to help your patients say no. See?
Yeah.
We love it on Dean's Chat. We bring it all full circle. Well, thank you both so much for your time. We'll definitely, again, we'll have to have both of you on, but maybe separately or combined again. It's been really fun. Thank you so much to our audience for watching and listening, and however you digest your podcasts. We'll continue to bring you leaders and innovators in our profession. Please feel free to leave a review. And if you're not already a member, subscribe. We'd love to hear feedback from the guests and the audience. And to both Dr. Hjelm and Dr. Hutchinson, we're going to send you guys a Dean's Chat mug as a little token of our appreciation. So
Thank
you can
you.
start your day the Dean's Chat way, as Dr. Arrett has coined, and now we're totally stealing. But nice, good sized coffee cup so you can kind of get your day going. So,
fantastic.
So good to spend
thank you
with you.
Yeah. Cheers, everyone.